Welcome, my dear students, to R.A.T.S in Pathology, Racing Against Time for Students. The topic for the day is vitamin D deficiency, which you would have read in your school days as well as in the first year. It can come as a university question or quite a few MCQs can be made out of this. Think of the subheadings. The subheadings will take you to the answer. Even if the question or the answer is going to be short, it is better that we divide it into the headings so that we do not miss any point. And these are the subheadings which I hope will be reflected in the class that is following us. And on the screen, I'm able to see a plethora of sources for vitamin D, including the sunlight. This I would like you people to kindly go through, recite, and reproduce. Whenever we talk about a vitamin deficiency, there are two important things. One will be the causes for deficiency, and two, what are the manifestations. Coming to the causes of vitamin D deficiency, it can be inadequate sunlight, dietary deficiency, malabsorption syndrome. This malabsorption syndrome need not be specific for any one particular substance. After all, it is a fat-soluble vitamin. Therefore, any of the fat and its allied compounds may not be absorbed. Derangements of vitamin D metabolism in liver and kidney disorders. Genetic disorders. Again, that has got a say. And finally, there will be an adequate intake, but we find that the end organs are resistant in responding to vitamin D. This is called vitamin D resistant rickets. The manifestations, there are two things mainly. In children, you have got rickets, and osteomalacia is the adult counterpart of rickets. Apart from that, you find that calcium metabolism is intricate with vitamin D. Therefore, there can be an interlinked hypocalcemic tetany, in which there can be neuromuscular dysfunction. Causes, manifestations. Manifestations. And we are in a hurry, we want to memorize, so the mnemonic badges. B for bone fragility, A for atrophy or muscular weakness, D for dental problems, G growth retardation, E enlargement of the liver or spleen, and S for skeletal deformities. So you find that this is a crippled patient virtually having a bent lower limb and a knock knee. The primary defects will be interference with the mineralization of bone. There are two things in the bone. One is mineralization and the other one will be ossification. There is a deranged enchondral and intramembranous growth of bone. And it occurs mainly in children between 6 months and 2 years of age. And in children, usually before the fusion of the epiphysis, you find any of the skeletal disorders will manifest most. The same thing need not be seen in an adult after the fusion of epiphysis. This is a little complex chart. I would like you to remember only two things. There is something called as calcipenic rickets and phosphopenic rickets. Remember these two words. So calcipenic, as I mentioned earlier, there will be a resistance to vitamin D. Malabsorption, lack of exposure to sunlight, 25-dehydroxylation, etc. are formed. There is a failure of 1-hydroxylation of vitamin D due to inherent deficiency of the enzyme. alpha hydroxylase. Also, there is an end organ resistance to vitamin D. Calcium deficiency and renal rickets are the other components of this. This is a little complex, but it is worth its weight in gold. Calcipenic rickets. Phosphopenic, it is mainly genetic, in which you can have disorders such as the Fanconi syndrome. This is a beautiful picture taken from the net. I would like you people to memorize it, draw it, and win marks. Delayed closure of the fontanelles. Over here, you find that the skull bones are not getting fused. Frontal bossing, projection. Dental hypoplasia. There is a weakness and the loosening of the tooth. Pectus carnivatum. Just like a bird's chest, you find that it is projecting outside, and there is a rackety rosary, beading of the ribs that could be seen. Swelling of the wrists and the ankle joints. Widening of the sutures of the skull. Craniotabes. Harrison sulcus. I find that on either side of this, there will be a depression which is called the Harrison sulcus, and bowing of the legs, either inwards or outwards. These are seen. So as you see here, this is normal. Here there will be a bow leg. Here there is a knock knee. So these are the important manifestations just simply by that. This is again an important flow diagram which you people would have read in your biochemistry. 7-hydroxycholesterol converted to pre-vitamin D3 and then vitamin D3. 25 calciferol, 125 hydroxycalciferol. And this will be useful for the mineralization of the bone, formation of the immune cells, as well as the development of the hepatocytes. Now, these are the various sources from the small intestine. And externally, there can be the ultraviolet rays coming from the sunlight. Also, you find that there can be a reabsorption of the inactive metabolites, which again become activated in the small intestine. So this is a nice flow diagram, which I would like you people to kindly draw if you get it as a question. The dictum is this. The moment you get a question like this, I do not want you to get less than 90% marks. Very simple. Bye. So the manifestations, again, I'm repeating it only for the sake of it. See how many things you people can identify. And radiology is important. You find that before the fusion, there is a lot of weakening of the bone, therefore it bends on its weight. There will be the bow legs, and again, it is a combination of both bow leg and a knock knee. These are all the terms. And this again is a mnemonic. Rickets. R-I-C-K-E-T-S. So R for rackety rosary, I for pigeon chest. The I comes over here. C for craniotabes, knock knee, end of long bones get widened, teeth get delayed in eruption, and hypoplasia develops, skull, fontanelle bossing, and delayed closure of the fontanelles. And this again is a clinical picture of it. These might not be very common nowadays with the awareness of the people. But even then, people are on sedentary jobs and even the adults can be developing. There is another condition called as hypervitaminosis. Whenever there is a deficiency, there can be an excess. The increase in the vitamin D can be because of unintentional poisoning, over intake, milk products, etc. Iatrogenic, there can be an accidental overdose. So you find that the inactive 125 is converted to active 125, and later on, this is the metabolism by which it is getting inactivated. Also, there can be other granulomatous diseases which can lead to activation of it. Therefore, there is hypervitaminosis. Sometimes it can be idiopathic hypercalcemia. So very simple. intoxication, iatrogenic, excess granulomatous diseases, or hypercalcemia. All of this can lead to hypervitaminosis D. And what will be the symptoms of this? There can be anorexia, gastrointestinal distress, nausea and vomiting, headache, nervousness, hypercalcemia, calcinosis, polyuria, etc. So this again, I would like you people to buy it. I have taken the class so deftly that it does not cross about 10 to 12 slides. Osteomalacia is an adult counterpart of rickets. If you write this one line, you get 1 mark. Decrease in calcium, vitamin D, or phosphate. There is a resorption of calcium. Therefore, the bones become weak, fragile, and there can be Looser's zone, wherein there can be a fracture. Teeth, there can be odontomalacia. Just like osteomalacia in the bone, there can be odontomalacia in the teeth. Decreased absorption and gastrointestinal bypass surgery can again precipitate this. One of the important things can be because of certain drugs, which we shall be seeing. So this is a thigh bone or the femur. There is a Looser's zone and a pathological fracture has developed. There can be incomplete mineralization of the mature bony matrix. So here you find it does not get mineralized. Therefore, there is no formation of mature strong bone. This is the bone marrow, of course. What are the manifestations and the investigations? So one thing that you'll have to remember will be long-term anticonvulsant therapy. Phenytoin sodium, etc. can lead to vitamin D deficiency. Insufficient nutritional quantities. Check it. Decreased metabolism of vitamin D or phosphorus. Renal tubular acidosis. Malnutrition in pregnancy, increased demand. Malabsorption. Hypophosphatemia. Kidney failure. Tumor-induced osteomalacia, oncogenic. Celiac disease, cadmium poisoning, etc. Also, you find that in the investigations, you look for the serum calcium. It is low and decreased excretion. Serum phosphate is reduced. There is an increase in alkaline phosphatase. Whenever the bone becomes weak, the alkaline phosphatase is mobilized. Therefore, the serum alkaline phosphatase is increased. Elevated parathormone. And finally, you find if you do a technetium bone scan, that will show increased activity, and also this can be due to increased osteoblast. The bone is becoming weaker, the body is reacting to it. So manifestations and investigations, kindly memorize. So this is a normal bone, either in a child or an adult. You find that the porosity is increased in rickets or osteomalacia. And this is a wonderful X-ray that shows the Looser's zones leading to pathological fracture. And there is a thinning of the cortex, as well as a decreased mineralization. Mercy.